Hello guys, hope I'm audible and visible. Am I audible and visible? Okay, so welcome back everyone. Oh, how was your INICET? Did it go well? So this is going to be a recall of pathology questions which came in the recent INICET. There was close to 26 questions which came in pathology, which is a significant number. Though there will be slight overlap with micro a little bit and your other subject a little bit, but hardcore pathology I would still say around 25 questions, which is 1/8 of the exam, is still a significant number. Hello Metnomic. So let's see the recall today. If there is any error in the recall, do let me know here. I will modify as per your feedbacks, and definitely I'll release an PDF file. I'll share it with you in your in the Telegram group as well as in your. Okay, it's fine. We'll see how it went Metnomic as well as in the Instagram. It's fine. So let's go ahead. The first things first. The Unacademy Learning Festival, which you must have been aware of by this time. There's a little bit of glitch in the software for downloading, enrolling it. That will get rectified by tonight or tomorrow max. It will be a 1 month subscription for 299 rupees. There's just a learning festival offer. You can use the best of it. Fine. We'll discuss happiness zone when we come to the question. Okay. In anemia of chronic disease, ferritin will be elevated. Okay. And there are light subscription, and there's one more AAMT mock exam which happens on May 14th. If you are in align with your May 21st NEET exam, if it happens, please do give an attempt at that. It'll be on easier side. Hopefully it will not demotivate you. That's a main goal for us. Please attend them and let's see how we can improve based on that. Fine. So there are a few more batches for you. If you are a subscriber, you'll know that. And there's UPC CMS as well as launching. Putting all these aside, we'll come to our questions, right? So this was the questions. Yeah, I'm coming to it, Metnomics. Sorry, I'm just scrolling it away. Fine. So this is the first question. I hope this question was correct. If there is any change in this question, do let me know. Which of the following is the correct T cell versus B cell ratio in the blood? It's T lymphocyte versus B lymphocyte ratio in the blood. Was there any change here? If this was the thing, it's fine. Again, I am not sure exactly how to put forward. I will give you the facts. You tell me what will happen in your main exam. Fine. Good evening, Ifat. See, normally when you take blood and you take lymph node, the amount actually changes. Fine. Okay, great. So in blood, the T lymphocyte percentage is around 60 to 70%. I am stating all the facts as they are in Robbins. Fine. And in blood, B lymphocytes ratio is around 10 to 20%. Okay. These are the facts which is given. Fine. No, B cells are not more. T lymphocytes are only more. Fine. Okay. In lymph node, it will be the reverse. T cell will be reduced and B lymphocytes will be more, right? This is the one which you'll have, which will be more in the blood scenario, right? So taking this into account, I'm not sure where to put the exact percentage into. Is it 3:4 or 3:1 or 4:1? I'm not exactly sure about that, right? Because if I take 20 and 30, it comes to 3:1. If I take on the lesser side 10 and 60, it comes to 6:1, right? So I'm really not sure of how to put. If I consider 20 as the B cell and if I consider 60 as the T cell, the amount is going to be 3:1, right? The correct ratio for B cell is to T cell is to B cell is going to be 3:1. Again, 4:1 or 3:1 is a very tiny variation. The answers might differ on different books. This is the basis on Robbins, right? I'm just going to base my thing on Robbins. It's 60 to 70% of T cells and 10 to 20% of B cells. So these two are very narrow considering these facts. These are the facts given in the textbook. So I'm just going with that. Fine. It might change. Okay, fine. As per like what Metnomic says, if there's no option of 3:1, obviously the closest option has to be 4:1. Then definitely in the PDF what shall be releasing, I'll erase 3:1 and I use 4:1 option. Fine. These are the facts. In future, if you have anything, we can go ahead with this, right? This exam particularly, there's a little bit more emphasis on your immunology, and these are very basic facts in immunology, right? Okay, we'll go to the next question. I hope this question was correct. If there's any error in this question, please let me know and I'll start discussing this question. This was a hit for quite a few of you, right? Which of the following markers are the markers for NK cell? I hope this question was correct, right? Yeah, it's a very bad question for quite a few of you. Okay, so NK cell markers, the original markers we all know was 16 and 56, right? So 16 and 56 are the general markers which everyone knew. But unfortunately, this question didn't have neither 16 nor 56, right? So both of them were absent. So it's natural killer cell. Natural killer cell is a separate subtype of lymphocyte. It's not a B cell, it's not a T cell, it's a separate cell, right? So CD3 is not going to be the right answer. Since majority of you have written CD3, it's not a T cell. There is a subset of cell called as NK T cell. Okay, this is one more cell. NK T cell will be CD3 positive. That will definitely be positive. But NK cell, pure NK cell will be CD3 negative. Go for that. Fine. Second, this also quite a few of you wrote. Whoever wrote CD25 as the option, I really applaud them for the reason you were thinking in the exam correctly and you're writing. Because you use a little bit of logic saying that, okay, this is interleukin 2's receptor, which is a fact you already knew. And interleukin is required for activation of NK cells. You must have definitely read that. That's the reason some of you answer for CD25. I'll tell you why CD25 is not the right answer. Can I say that for an NK cell activation, I need interleukin 2 and not for normal NK cell, and for smooth functioning post activation? No. So CD25 will be momentarily raised. It will not be present throughout. Only when there is a requirement of activation, CD25 elevates and it goes and gets activated. So before activation of an NK cell, it will not be there. After activation of an NK cell, it will not be there. So it's a momentary rise. When something is momentary rise, I cannot use them as a marker of a cell. I cannot expect a lymphoma where I'm going to use the CD25 CD markers to be always having that elevation, right? So since it's a momentary rise, it's not the right answer. But your thought process of interleukin 12 receptor, interleukin 2 receptor being CD25 and interleukin 2 is being required for NK cell activation is perfectly correct, right? Okay, next CD68. But this is something you already know. You must have read CD68 before. Where have you read CD68? We have read CD68 in one of the tumors. What was a tumor? You must have read CD68 in your Langerhans histiocytosis. It's a histiocyte marker, right? It's a marker for macrophages or it's a marker for histiocytes. So when it's a histiocyte marker, obviously it's not a marker for NK cell, right? It's a histiocyte marker. So CD3 is a T cell marker. 25, yes, it's interleukin 2 receptor. I'll give you one more extra information regarding 25 soon. And obviously the right answer is CD94. This is a new information, and if you have made a mistake in this question, please don't be so hard on you that you are not a good student. It's a new information, that's all. Every exam I'm going to learn new informations, right? We should not miss the old and the known concepts. The new, fine, that's completely fine to make an error, right? So your CD25, as I said, if something has to come in CD25, there are few places CD25 is required. The first place is CD25 is a marker for mast cell lesions. Remember them. If I'm going to go for pathological conditions, your mast cell leukemias, mastocytosis, for all of them CD25 is required. That's one of the markers for mast cell lesions. Do remember them. For a normal thing, if I'm going to consider CD25 in a normal cell, have you read about something called as Tregs? What is the function of Tregs? You must have heard about Tregs. It's fine, Srujana. Tregs function. T regulatory cells, right? T regulatory cells will have abundant of CD25 receptor. CD25, do remember that, right? Okay, Chilpil, I'll come to this. See, when you have an exam, you are not expected to know everything first of all, right? Second, it's impossible to teach entire medicine, right? So all the teaching, whatever happens for you, any platform for that matter, we align the teaching to the questions you've been asked for the past few years. That's all. I cannot teach everything in pathology with the stipulated time of time. Neither can anyone, right? Having said that, if I don't know this, it's not that I will not pass the exam, right? There's a few things. It's a new information. That's all. We learn it. It's a very, very old information for pathology because we use CD94 as a marker for diagnosing NK T cell lymphomas, but not being taught for undergraduates. That's all, right? So examiners ask something new, that's completely fine. Okay. Okay. So this question, answer. This is a very simple one. This has been taught to you. It's a simple one for sure. Option D, right? B, D. Okay, see, this is a very simple question. I'm going to take the answer right from the question. So this is what I want you to do in the NEET exam. If something you feel is something new is coming. I'm having a neurosecretory tumor, right? So can I say medullary carcinoma thyroid, I have secretion function, calcitonin, I do have, right? Pituitary adenoma, do they secrete? Prolactinomas, ACTS secreting tumor, right? Lots of them, they do secrete. Paragangliomas. Yes, happiness. Some of them are not. I don't know about OBG questions, but here some of them are definitely a bit of a higher level, right? Paragangliomas or a pheochromocytoma, that is also, you know that they do secrete catecholamines, right? So of these four options, three of them are secretory. See, this is not a difficult question. You know already they secrete because either the presentation or the tumor markers is based on the substances what they secrete. But when I take an adrenal cortical tumor, I don't have a tumor marker. I don't have any secretin, right? And adrenal cortex, it's an epithelium, right? It's not a neurosecretory organ at all. Adrenal medulla is a neurosecretory organ, but not a cortical lesion, right? So this do not secrete and they don't have a neurosecretory granules. There's no neurosecretory granules in adrenal cortical tumor, hence that's the right answer. It's a very simple question. This format of asking might have been new, but the facts, the concepts, what you know behind this question are definitely there, right? If this is true, can I say all of them in an electron microscopy can have blackish neurosecretory granules? They do have, right? In pheochromocytoma, you had an electron microscopy, like lots of your black granules. Small cell carcinoma, black granules, right? All of them are neurosecretory, fine? Yeah, great. Okay, super, fine. This I don't know the fourth option. You have to fill in the fourth option and let me know if there is any error in the three options. Right? I hope this question is correct. All of them are true regarding following innate immunity components except these two were in the options for sure. One of the student told neutrophils, so I added it. Fourth option I'm not sure, but they were also a part of innate immunity, right? So of these four options, the only one which is not a part of innate immunity is CD4 T cells, right? There are two lymphocytes. Okay. B cell was there in the option, not CD4. B cells and T cells, B2, fine. That comes under the regulation thing. B cells and T cells, the activated B component and the T cells are the only one which form the adaptive immunity. Okay, I'll take complement as one of the options and B lymphocyte as the other. There are no CD4 lymphocyte T cells, is it? Was it B cells and complement? Okay, got it. Defensins were there instead of neutrophils, fine. Defensins are granule components of neutrophils, that was there, right? Okay, fine. So anyway, B lymphocytes and T lymphocytes are definitely components of adaptive immunity. Rest everything comes to innate immunity. This again was a PYQ. Gamma delta T cells are T cell subtype, but they do form one of the important components of innate immune complex. Fine. Okay, great. I'll rephrase the question. I'll give you the PDF as an answer. If possible, I'll give the references. Thank you, Prathamesh. I'll take all the four options. Okay, great. Fine. Okay, this I'm not sure about the image. That's a simple reason I'm not given up the image. Okay, Shankar, I'll take that as well. Fine. I don't know what happened because quite a few of you said that there was a strawberry gallbladder. But if these were the four options, it cannot be a strawberry gallbladder, right? Because cholesterolosis and strawberry gallbladder is the same, right? Naveen Kumar, gamma delta T cell is not an NK cell. It's a separate type of cell, T lymphocyte, which gives your innate immune response in the GIT. Fine. I'm not sure if these two were the right answers. I'm not sure this will be the right answer because both are same, right? So the only possibility is either CA gallbladder or a multiple polyp. I have not put an image for the simple reason. Okay, what should be the answer? Okay, great. So if you're finding it difficult to identify between CA and a polyp in a gross image, I'll tell you a simple reason. Okay, see, let's assume this was an open up gallbladder. Was there an image which had big lesions like this, big single thing, or tiny things like this? What was the image like? It was a single one or tiny multiple ones, because that will easily help me to identify what it is. It is a big one. Okay, again, it should be a complete answer. The tiny one has to, if it's tiny ones, I'll go with polyps, because gallbladder polyps will not become big. If it's a big single one with looking very hard appearance or indurated appearance, it has to go for cancer. Fine. Because gallbladder carcinomas are adenocarcinomas. They are never multiple. They are single ulcerative proliferative lesion. Fine. If you're going to say one big and multiple tiny, I am not sure what to go for. I will still prefer a cancer, because if it's multiple polyposis in the background and a big carcinoma, I will prefer carcinoma as a diagnosis and not multiple polyposis. Fine. See, yellowish appearance can be there. Yellowish appearance can be there in a normal gallbladder also. When I have these two options as contradicting thing in the same question, I would prefer cholesterolosis or strawberry gallbladder is not the not the answer. Fine. Okay, Pratmesh, I'll take your point. Generally, why cholecystectomy is not done for gallbladder carcinomas if I know the diagnosis beforehand, but sometimes they will present as in cholecystitis. Do you think for a cholecystitis someone will do an MRI or something? No, right? I'm going to have obstruction, pain, you open and you remove it. Sometimes after removing only you know there's something inside, cancer or polyps. That's might be the reason you gallbladder cancer can be picked up incidentally. Fine. Yes, you can share me in my Telegram group, or personal message me on Telegram or Instagram. I'll definitely give you a better answer if I get the image. Fine. Keeping in mind these two are the things which will help for you. Fine. Okay. Okay. This was a very simple question. Options. I hope both the tables are right. Okay. It is match the following. It is a simple one, right? For every match the following, go with the one which you are definitely confident of. Here I would say retinoblastoma and RB is the one which is very easy. And obviously the second one which is very easy for us is Burkitt's aneurysmic, right? That's definitely easy. Neuroblastoma NMIC also, you must have definitely known about that. Fine. So always go with the easier options which you know. So answer should be this, I hope. Option B here. Right. Pleomorphic adenoma, plague 1, though it is, yeah, I'll come to Italy heavens. Though it is not useful for diagnosis, that's a marker seen in pleomorphic, a mutation seen in pleomorphic adenoma. Maybe in future it may come for diagnosis, right? Okay. NMIC rearrangement was a semic translocation. Can I say rearrangement is also a translocation? MYCN and NMIC are the same, fine. Rearrangements are also translocations, right? It's getting rearranged. In some words I use translocation, in some places I use rearrangement, that's all, fine. Okay, so NMIC is going to be there in your neuroblastoma and plague 1 is going to be there in pleomorphic adenoma. Since this, I would personally feel this is not a difficult question, because you definitely know neuroblastoma and Burkitt's lymphoma, that everyone here knows. If I know two of them in a match the following, which is not going to be confusing, other two are definitely easier for us to pick up, fine. This I would still put on the easier side only. Okay, this is not a new one. I would say this is a very old one, because this term is not used anymore. So it clearly shows that there is a big HOD sitting there who's creating questions, right? It's Entosis. Entosis is a terminology which has been removed from Robbins. It's not used at all, right? Entosis is a thing that I'll use Entosis in a way that you can easily understand. Can I say that a tumor cell consume another tumor cell? If you see it's not emperipolysis. If you have a tumor like this, an adenocarcinoma like this epithelial cell of an adenocarcinoma can go and eat and cell again, right? So entosis is something which is said that a tumor cell can engulf and eat another tumor cell, causing cell death in a tumor, right? It's like cannibalism. Cannibalism happening in a tumor cell is called as an entosis, right? This term is not used anymore. So personally, I would say that if you made a mistake in this, completely fine. You are far ahead of the examiner. I don't know why they asked this. Emperipolysis is a passive transition. This is a mode of cell death. It's going to cause cell death. Emperipolysis and this main difference is there is no cell death in emperipolysis. So emperipolysis is like a downgraded thing of autophagy. What happens in emperipolysis? Let's assume there's a macrophage or megakaryocytes. So my lymphocyte here is not having enough energy. So what a lymphocyte does is goes and stays here for some time. For some time it stays there. Once I have good amount of energy, the lymphocytes come again and then survive. Emperipolysis is like a transient process where I'm just going to stay there, that's all, right? Okay, RBC in amoeba, I would use the term phagocytosis, and that's a pathological term where amoeba eats the RBC and destroys them. Emperipolis is a normal phenomenon where my lymphocyte goes and stays inside a macrophage or a megakaryocyte. Fine. This is type of cell death which happens in neutrophils, and there will be no cell death in emperipolis. Okay, this. Okay, I hope this question was correct as well. If you have any error in the question, do let me know, because I'll try to definitely give you the PDF by the end of the day or max tomorrow. Was there any change in this question? Okay, it's right. So it's a simple question. Where some of you might have made a mistake is first option is keratin pearls. Okay, I'll change that. Okay, which of the following is not a feature of pleomorphic adenoma? I am sure you must have had no problem with myopathy cells. You must have had no problem with chondroid areas as well, right? The only confusing things are option A and D, right? So we'll approach this from the information which you already know. Clinically, if you see a patient with facial nerve palsy, you'll think of a benign lesion or a malignant lesion. Clinically, if you see a patient of facial nerve palsy, you'll think of benign lesion or malignant lesion. You obviously will think of malignancy, right? See, that's what you know. I want you to use the knowledge you already know to extrapolate and to write an answer. If I have perineural invasion microscopically, can I say clinically it will cause facial nerve involvement or facial nerve palsy? Because it's going to invade the nerve and destroy the nerve, right? So this is a feature of malignancy only. When I have the term pleomorphic adenoma, it is going to be malignant. It's not malignant, it's a benign term. So I will not see perineural invasion in case of pleomorphic adenoma, fine? I can see them in adenoid cystic, I can see them in mucoepidermoid, I can see them in any carcinoma. More commonly in adenoid cystic, that's all, fine? If there is perineural invasion, I'm going to think of a malignancy because clinically I know that if nerve is damaged, it's a malignancy, right? Now let's come to keratin pearl, right? So why keratin pearl was a confusing point for most of you is we must have read keratin pearl in case of squamous cell carcinomas, right? That might be the reason it's going to be confusing for both of us, for most of us, right? So when I say keratin pearl, I'm going to ask you two questions. Tell me which is more in favor of squamous cell carcinoma. Is keratin pearl more in favor of squamous cell carcinoma, or keratin pearl plus dysplasia is more in favor of squamous cell carcinoma? Which is more in favor of squamous cell carcinoma? Just keratin pearl or keratin pearl with dysplasia? It's obviously keratin pearl with dysplasia, right? It's plus dysplasia is obviously more important for me, right? Now let's go back to the question why we had a problem. So we read patterns of neoplasia where we know that if I see pearl, I'm going to think of squamous cell carcinoma. It's not just keratin pearl, keratin plus dysplasia. Because when I see keratin pearl, it says it is squamous origin, that's all. It will not say it is squamous cell carcinoma, it will say squamous origin. It's for origin, it's not for the cancer. We also read that when I see glands, I call it adenocarcinoma. Does gland is equivalent to adenocarcinoma? No. Gland plus dysplasia is equivalent to adenocarcinoma. So gland is the morphological hallmark of mimicking the parent tissue, that's all. So keratin pearl is the origin. So keratin pearl can be seen in normal epithelium also. Keratin pearl can be seen in craniopharyngioma also, which is again benign. Keratin pearl can be seen in seborrheic keratosis also, which is again benign, right? It can be seen in many people, right? Okay, it's completely fine. It's D1. D is the right answer. Okay, D is obviously the right answer because this is malignancy. Whenever I'm going to have something malignancy, clinically also facial involvements points towards malignancy. Microscopy also perineural inversion points to malignancy only. Keratin pearl is a finding of squamous origin. If the question says dysplasia plus keratin pearl, obviously that's going to be a wrong answer. Fine. I hope that's clear. Option I would prefer here is perineural invasion if it's the same question and same 4 options. Fine. Got it. Great. This was a PYQ. You shouldn't have made a mistake here. Yes, Pavani, the answer is perineural invasion, which is not a feature of pleomorphic adenoma. Option is answer D. You shouldn't have made a mistake here, right? This is a simple one. You must have seen this. If this is the same image, it's a PYQ from AIMS 2014 or 15, I think. It's a old question, but it's completely fine. Toluidine blue, yeah, it's a metachromatic cell. It's a mast cell. It's a very easy one. We did discuss this already, like Government said. I'm not going to discuss anything more here. It's an old question. Please don't confuse, at least in PYQs. We'll discuss this sometime later, maybe again. Okay. Okay. Is the options right? I hope you didn't make the same mistake in the exam, Pratmesh. Question and options are correct? Fine, I'll change it now. I'll change one of the options to plasma cells. Till then, the answer will be the same. Great. Okay. Okay, differential expression of genetic material in parents. That's fine. I'll add chilpal, but still my answer is going to remain the same. It's not incomplete penetrance. When I say differential expression of parental genomic material, it's always for genomic imprinting, right? It's always for genomic imprinting. It's not incomplete penetrance. I'll tell why. When it's incomplete penetrance, it's difference in the genetic expression. If it's difference in the genotypes or gene or difference in the phenotype. Incomplete penetrance. Incomplete penetrance is a difference in the phenotype, right? It's the expression of the patient. It's not the genetic material at all. But when I take genomic imprinting, the gene itself gets silenced. The other name for genomic imprinting is a differential expression of genetic material specific to parents. In other words, either the entire mom's chromosome will be silenced or the dad's chromosome will be silenced. That's why differential parental expression. When I say differential parental expression, it means genomic imprinting. This is a physical expression, this is a phenotype. There's no problem in the gene in incomplete penetrance. The gene will be the same. And if the patient doesn't have physical symptoms, I call them incomplete penetrance. Partial penetrance, again, kind of same like incomplete penetrance. Mosaic has nothing to do with the differential expression related to parents, right? Differential expression of parental genomic material is imprinting disorder, fine? This term might be new, the differential expression, but that's how geneticists generally mention imprinting. A mixture of this might, I would say this is not a question for undergraduate at least. You should have asked for a postgraduate, that would have been better. That's fine. One or two questions here and there, it's completely fine. Okay. This option is correct. If the questions and options are correct, fine. It's okay, Chili Evans. We'll not make the mistake again when we have similar questions in the future. Fine. Okay, if these options are correct, did this bother you guys? The dicentric chromosomes, did it bother you guys? NOR instead of which, Pavani? Can I keep it based on this? Okay, when I have a dicentric centromere, dicentric chromosome, right? It was not centromere, I suppose. It should have been dicentric chromosome. Was it chromosome or centromere? It should have been chromosome. There's nothing called dicentric centromere. When I have dicentric chromosomes, again my answer is going to be still G banding only. I will tell what does a dicentric chromosome mean. Then we'll decide what I'm going to use, right? So this is my normal chromosome, right? In a normal chromosome, I have a single centromere, that's all. When I say something as dicentric chromosome, which will have like this, right? When I have a chromosome like this, right? When I have a chromosome like this, can I say it will cause translocations abnormally and it will cause cancers? It can, right? This kind of a complex chromosome. When I have three chromatids attached by two chromosomes in a single form, I call them a dicentric chromosome. This is one of the commonest thing seen in your cancers karyotype. When you do karyotyping for cancers, I'm sure you must have heard this. Have you heard about, in leukemias especially, have you heard about something called as complex karyotypes? Where you must have read that when you have more than two chromosomal abnormality, have something called as complex karyotypes, right? It's cancer's karyotype, right? Whenever you have dicentric chromosomes, it's a classical finding seen for tumors, right? Right? That's all. I'll tell what is C banding. Whatever may be the karyotyping, the banding what is being done in real life for diagnosis is only GIMSA banding and G banding. Other bandings are for reverse banding, C for centromere based banding. I'm not going to do in this, right? When I have a karyotype, normally karyotype also, normal G banding also will stay in centromere, not just C banding will stay in centromere, right? because centromere is a GC rich region. You must have read them in your biochemistry. So centromere will definitely be dark, that's all. Fine. Okay, Pratmesh, other banding is also present. No. Again, chill pill, leave Google, right? See, it is for diagnosis. If it's for diagnosis, I'm going to go with G banding only. There's no other place. I'll show you karyotypes with dicentric chromosomes in a proper G banding. G banding is what we have been doing here. C for centromere based banding. See, centromere is a GC rich region. It will definitely be highlighted in normal G banding also, because G banding has the bands. The color of the dark band is GC rich region and the light band is AT rich region. That's all. So everything can be picked up, fine. Okay, I would still prefer G banding, since I prefer the examiner wants to ask for a clinical based question. It's theoretical part, we should go back and look at it, fine. Okay, other banding is also there. R stands for reverse banding. When I say reverse banding, whatever is dark in G banding will become light in R banding, and whatever is light in G banding will become dark in R banding. That's all. It's called reverse banding, fine. Okay. These questions options are correct. Is the question and answers correct? I hope it is. Options are right. Okay. Rett syndrome, Asperger, G6PD deficiency. I think this is not a problem. Rett is a very simple answer, right? OTC deficiency. Have you also read that OTC deficient, ornithine transcarbamylase deficiency, is an X-linked dominant disease? This is an X-linked disorder. Most of the enzyme deficiencies are X-linked recessive disorders only. Fine. Okay, thank you, Pavani. Tuberous sclerosis is autosomal dominant, right? It's X-linked disorder. X-linked recessive is the common pattern of presentation for OTC deficiency. Dominant is also a pattern of presentation, but this is a PYQ, right? Rett is definitely an X-linked dominant disorder. It's not a recessive disorder. So I think there should have been no confusion in this. If you got confused, ignore that. I'll change the tuberous sclerosis while I'm going to share the PDF with you. Fine. Okay. Okay. I hope this question shouldn't create waves for us. And I hope for all of you, there's a uniform question displayed, because some of you say there was a knot and some of you said there was no knot. So I'm not going to go for anything. So I'll leave it to you. You know which is, these three will be elevated. This one will be reduced. So I'll leave it to you what will be the right answer. Fine. So I hope it must have been a negative question only, like not elevated, or all of them are elevated except. Some of them should be there. If it is there, the answer is factor 11. Factor 11 and 13 mostly reduces. Rest predominant of the coagulation factor increases. Fine. Okay, I'll add Duchenne's also in the other option. Yeah, I'll add Pratmesh. I'll add Medmonic and Pratmesh. I think instead of Asperger, was it Duchenne's? I'll add Duchenne's. Fine. I'll change that. Okay, great. Okay. This also a simple question. We did have few questions which are difficult, but predominant of them were simple, at least with respect to pathology, right? So which of the following is not screened during blood transfusion? Most of you guys know the answer here. If you must have definitely worked in blood bank little bit by collecting blood at least. HIV is definitely screened, syphilis is screened, malaria is screened, right? Dengue is definitely not screened. Dengue fever, we don't screen for dengue fever, but if a patient had a dengue fever, we'd at least say that we don't collect blood for at least 4 to 6 weeks. Just for, not for the fever part, not for the transmissible part, just for the part that patient is to recover from an illness, we don't collect blood for 4 to 6 months, right? Everyone cares about dengue fever, right? When there's an epidemic, all of us will care about it, right? These are commonly, apart from this, hepatitis is one more disease which we routinely screen, but dengue is not generally screened, right? Was this there in the question? Because some of you students said that this question was not there. Some of you said this question was there. So I'll leave it to you if it's there or not. I don't know if this is the same image there, but some fish image was given, right? As a classical image of fish, right? You shouldn't have made a mistake here. This was a perfect image of fish. Just because there is a hyphae test there, that's not the right answer, right? Sanger sequencing will not look like this. This is a microscopic image. I'll tell you, anything which ends in sequencing, just like a general statement, it is a test which is done on computers. It's not a test done in microscope. Fine. Anything which ends in sequencing is a computer-based test. because only computer can compute all the information which comes from a sequencing. So if you have a computer screen there, think of a sequencing. Otherwise, just think of sangars. Think of fish. Your sequencing image, if it comes, it look like this. This is how sequencing image looks, and it will be written here ATCG, ATCG. The nucleotides will be written in below, and there'll be graph on the top. Fine. So that's how Sanger sequencing image will be there, if at all it is there. It's fine, Pavani. Whatever it is, it should be there. Okay, I'll come to why lymphocyte is used in fish. It's not that lymphocyte should be used in fish. I can use any cell in fish, any cell which stays in the interface, it can be used. Generally, lymphocytes in a peripheral blood are inactive cells. That's the reason we are going to go and use that. Fine. It's fine, Abdul. No issues. Don't worry about it. Okay. What was the case, Pratmesh? If I can, if you have any memory of the case, do let me know. If the question was the base same to identify what image it is, we'll keep that. I'll add the case scenario if you give me a proper case scenario as a recall. Fine. Okay. If the final outcome is this, I think that shouldn't be a problem for us. Okay. This question, whoever asked, really shouldn't is either not practicing medicine or has retired from the profession, right? Because for this patient of a 75-year-old pain in the hip, do you think anyone will do a biopsy? No one does a biopsy, right? I don't know why they ask these redundant questions. They should not happen. At some point of time, they should not happen for sure, because synovial biopsy is being kind of eliminated from routine practice. We don't do synovial biopsy at all, except for some diseases called as pigmental villonodular synovitis, where it's a tumor. I need to have a microscopic finding. Fine. Okay. So this is totally a theoretical question. The only thing which some of you, this image was shared by one of the students, where I have this papillary appearance, right? Two images are there. I'm searching for the other image, Chilpil. If you get that, do share with me. But students said there was a papillary appearance. When you have papillary projections on a light microscopy, it was only one, which is rheumatoid arthritis, right? It's really, that should change, Pratmesh. I will still tell, even if I face the examiner in real life also, it shouldn't happen. This is not required at all for an undergraduate. Rheumatoid arthritis, if you can clinically diagnose, do a proper CRP as per the American classification, diagnose rheumatoid arthritis, treat with disease modifying drugs, and acutely manage with NSAIDs, that's enough for a doctor. PANAS is just for understanding, right? The papillary projection must have been PANAS. And when PANAS comes, obviously the joint space, that's there in your history as well, joint space will become narrowed, right? Because this is my joint space normally in a small joint, and if my synovium becomes bigger, hyperplasia, it will become the same, right? Other things might not have PANAS, right? So osteoarthritis will have total destruction of everything. Lyme's is an acute problem, and TB hip, I should see at least something such as a granuloma. Since there is a papillary projection, microscopy wise, it will fit into your rheumatoid arthritis. 72-year-old, can I say that deformities of rheumatoid arthritis can happen in very elderly patients as well? Yes, I as well as Tilly Evans, 72-year-old is an odd finding, but at the same time, hip joint is also an odd finding. It's a very extremes of age, but if it had a granuloma, I am not sure about it. Osteoarthritis might not have a papillary projection. In an elderly person with an osteoarthritis, it will destroy entire synovium, right? Because what happens in osteoarthritis, synovial damage first, then the articular damage second, then your synovial fluid kind of goes into the bone, which causes your subcortical erosions, right? So that's what happens there, fine? Lyme's arthritis, I am not the right person to talk about the Sahana. I will leave the presentation to medicine person. Microscopy of Lyme's arthritis is going to show lymphoproliferative changes, that's all. Yeah, if this is the presentation and this is the image given of papillary hyperplasia, I would go with rheumatoid arthritis. If there is any change in the image, if you can get a better image, I'll be able to comment better if the answer changes, fine? That's true, but if there is a papillary projection, still I would prefer rheumatoid from microscopy, fine? Okay, this this is a good question. The examiner wanted to play with you with options, right? This all these options are right. The options were given by you predominantly. Which of the following is correct regarding autophagy except, right? Happens with an excess protein inside the cell. Autophagosome can bind with any cell organelle. Autophagosome binds with lysosome to form phagolysosome. And autophagy, is it except or which of the following is correct? Was this there? It should be which of the following is correct regarding autophagy, right? Was it all except or which of the following? Was except there or not? That is my only concern. Except was not there, right? Multiple correct option type, false is asked, which is correct is asked. Fine, I'll read through the options. I'll tell which is correct, which is not correct. You decide what the question stem was, right? I prefer except was not there. Happens when there's an excess of protein inside the cell, right? When do you think autophagy happens? When do you think autophagy happens? When there's a reduction in the energy and protein, or when there's an excess of protein in the cell? Which of the following should be fitting the answers? Autophagy will happen when there was a less content in the cell, right? When my energy is reduced, when there's any amount of stress, when there's something my cell is not able to cope up, that's what is going to trigger autophagy, right? When there's a reduction in the protein, right? When there's reduction in your protein synthesis, reduction in your machinery of apparatus of functioning of a cell, autophagy happens. It's cell conservation, it's an energy conserving process, right? Autophagosome can bind with any organelle. Can it bind with any organelle, or it should bind only with your lysosome? It should bind only with lysosome, right? Autophagolysosome can engulf any organ, but doesn't mean that autophagosome can bind with any organ. It should form an autophagosome. My autophagosome should bind with lysosome, which forms autophagolysosome. I'm writing APL for autophagolysosome. This in turn can eat any organelle. That is different, right? But autophagosome can bind only with a lysosome. It cannot bind with any organelle, right? So this statement is also wrong. Fine. Okay. Autophagosome binds with lysosome to form autophagolysosome. Option C is right. That's a way it's being formed. And autophagolysosome will definitely go and eat all the other organelles, whichever is consuming the energy. Fine. Autophagosome is a single membrane bound structure. No. Autophagosome is actually a double membrane bound structure. It's double membrane. If you remember the process of autophagy starts with endoplasmic reticulum as the first thing. Then I have something called an initiator protein and elongation protein. It's not a single membrane structure, it's double membrane structure. If this is my endoplasmic reticulum, this endoplasmic reticulum curves on itself and have a few more proteins added to it, and finally it kind of becomes an autophagosome. So autophagosome is always a double membrane protein. Fine. I'll see it's actually, I'll change in the final version, fine. It's a double membrane thing, and this will bind with lysosome, forms autophagolysosome that eats excess of whatever is excess in my body, fine. Okay. If option A says it's an accumulation of proteins again might trigger apoptosis generally than autophagy. If it's accumulation of a misfolded protein or anything, it can trigger apoptosis than autophagy, right? If the question is which of the following is correct, I'll go with option C. Option C is the right answer. Other things as of now looks wrong, right? Okay. Options are right. The options are right, I hope. Fine. So if they are right, let's see what's the answer. Okay, Shakshi, I'll take that and I'll give the different permutation combinations. Fine. What do you think is the answer here? It's a very simple question, right? The options might be wrong here. Some of them, was neuroblastoma metastasis an option? Was that an option? And some of them said there is a small cell osteosarcoma as well. Okay, they are making life much difficult for us. Fine. Okay. Was there any other pointers apart from the above in the question? Small cell osteo is not the right answer. I will exclude small cell osteosarcoma. That's not the right answer. Chondroblastoma is not the right answer. Synaptophysin was also there. Okay. Was MIG2 image any inputs on the image, please? If you can, guys, can give me an input image. Any input on image. Synaptophysin was given. I'll take that. Any input on the image per se. Histopathology was given. Okay. Fine, add the image. Periosteal reaction was there and it's mid-diaphysis. Fine. Are you guys sure synaptophysin was given? Because if synaptophysin is there, my answer is totally going to change. Are you guys sure about synaptophysin? If you're sure about synaptophysin, I would prefer neuroblastoma metastasis over an Ewing sarcoma, because Ewing sarcoma is not positive for synaptophysin chromogranin, because synaptophysin and chromogranin positivity in Ewing's is around 20-30%. Ewing's is not positive for synaptophysin. Ewing's is a very undifferentiated tumor. If it is synaptophysin positive, it's a neural differentiation. So I would prefer neuroblastoma metastasis. Fine. If it's synaptophysin positivity was there, because metastasis can also happen in the metaphyseal region. That's a common site of metastasis in a bone. Small round blue cell morphology is common for both neuroblastoma metastasis as well as this. Okay, I'll come to MIG2. MIG2 or CD99, right? I've told this before itself. MIG2 as well as CD99 is a very non-specific marker. MIG2 can be positive in many things. If you have listened to any of my lectures regarding Ewing's, I would say that CD99 is something which is not useful at all, because CD99 is positive in leukemias, lymphomas, most of the blastemal tumors, including Ewing sarcomas. Right? So because MIG2 is a very non-specific marker. I wouldn't diagnose a Ewing sarcoma in a real life as well as an MCQ just based on MIG2. If synaptophysin was there in the question, I would prefer neuroblastoma metastasis over Ewing sarcoma. If it is not there, diaphyseal lesion, small round blue cells and MIG2 positive, I'll think of an Ewing sarcoma. Fine. Okay. If synaptophysin was there in the diagnosis, neuroblastoma metastasis is much more correct answer, because that's also diaphyseal, that also small round blue cell. MIG2 is CD99 only. Fine. Okay. I would prefer neuroblastoma metastasis here. Okay. Okay, then I'll go with neuroblastomas. Fine. Okay, next. Was this question correct? I'll change the questions and give you the PDF with my proper explanation regarding every question. It's partial aneuploidy. When you have a partial aneuploidy, this means partial monosomy or partial trisomy, right? Both it's included in partial aneuploidy. It can be partial monosomy or a partial trisomy, right? Cre-do chart is a micro deletion which goes into your partial monosomy. It's deletion of one half of the chromosome 5, so it's going to be a partial monosomy reaction. Fine. So this answer is going to be Cre-do chart. I just want you to remember something on partial trisomy. Partial trisomies, I am not able to understand which one is not hyperplasia. Partial trisomy is very common in Robertsonian translocations. Remember this. Maybe sometimes later after exams I'll talk about what does partial trisomy mean and how is important Robertsonian translocation. Just for now, remember Robertsonian translocations has frequently partial trisomies, which leads to abortions. Partial monosomy is Cre-do chart. Fine. Okay. This was the right question. I hope the options are right. Okay, fine, Vivek. That doesn't change the answer. It will be the same. Fine. Was the question correct? Any error in this question? Right, fine. It's a technique for allele frequency, right? A technique for allele frequency, low allele frequency. Fine. Okay. What's the answers you guys wrote? Most of you. Was this Sanger sequencing or NGS? That is one thing which I want to ask before going to the discussion. Was it Sanger sequencing or NGS? Next generation sequencing. I mean next generation sequencing. Fish was there. You're right, same fish is the answer. It was Sanger, right? Okay, fine. Okay, great. Fine. So before understanding this, we have to understand what does an allele frequency mean. Okay, only when I understand what does an allele frequency mean, I can try to explain what is the right answer. Fine. So when I say allele frequency, let's assume for an example, I take 100 people. Of 100 people, let's say 90 of them have black color hair, natural black color hair, and 10 of them have naturally brown color hair. Fine. So these two, can I call them two different phenotypes? Black hair and the brown hair. And whatever gives the brown hair, that allele is what I'm going to work about, right? So that frequency, in this example, the allele frequency of brown color hair is 10%. Am I clear? Black color hair is 90% and brown color hair is 10%. So the allele which gives brown hair to one particular person is 10%. That's clear, right? So this is what I'm going to call it as an allele frequency, fine? So when I say a low allele frequency, in general, I will call something as a mutation if it is less than 1% of the population. I hope we have discussed this somewhere. If any genetic change in our human beings is more than 1% of the population, we call them variation. It's not a mutation. Only when it's less than 1%, we call them a mutation. Like I said, an example of black hair and brown hair, more than 10% brown hair, which is a variation, it is not a mutation. I don't call a brown hair a mutation. We don't call a blonde hair a mutation. Only when it's less than 1% is a mutation. When I use the term low allele frequency, it's less than 0.1%. It's a very, very less one, right? Yeah, pleomorphism or variations. You must have read about copy number variations and single nucleotide pleomorphisms. Those are the ones which are more than 1%. When something is less than 0.1% in the general population, I call them low allele frequency. The problem with low allele frequency is the normal PCRs will not be able to pick it up. When it's less than 0.1 in the sense, it's very, very tiny amounts, right? When it's very tiny amounts, I need an in-depth analysis. For an in-depth analysis, I would have preferred NGS as the answer than a Sanger sequencing, because NGS has more depth in analysis compared to Sanger sequencing, right? If this is the only question, if there's no change in the question, my vote will go for NGS then Sanger. If NGS is not there in the option, I would prefer Sanger sequencing, fine? Because other tests cannot pick up low allele frequency mutations, which is very, very, very tiny mutations, fine? In a given population, okay? This is tough. I do accept it's very tough. This is not something required for a level. If you have ignored this question and let it go also, it's completely fine, right? You will definitely get a good score even without that, fine? I will talk about that sometime else, Pratmesh, digital PCR. Okay. Digital PCR also can take care of to some extent, but not something with very low allele frequency. It is an upcoming thing. It can take up some extent, fine. Yeah, it's a new term. Digital is attracted more. Digital PCR has a little bit more advantages than a normal PCR. Like I can do a complementary genome library and other things, fine. This is a very simple question. Not an age-defining illness. We are going to go for melanoma. Okay. It's an old question. This is a PYQ. After this, we'll see. After finishing everything, we'll see which all questions we should have attempted, and it's a very simple paper, and we'll realize it's a simple paper, right? At least with respect to pathology. This was a question, I suppose. Some of them said that which is the most likely finding in a peripheral smear. That's completely fine. Okay. A 45-year-old person presented to the clinic with easy fatigability. On examination, she was pale, 6 grams hemoglobin per stage. An elderly woman with anemia. My first and only thought is going to be, iron deficiency anemia. I'll go only for iron deficiency anemia, nothing else. Everything else comes secondary, right? So first possibility is obviously iron deficiency anemia. If I'm going to have a patient with iron deficiency anemia as the differential diagnosis, which is the right answer? Microcytic hypochromic is the right answer, right? Poikilocytosis. Can I diagnose IDA only with poikilocytosis? Or can I say poikilocytosis can be seen in multiple other diseases as well? It can be seen in multiple other diseases as well. It can be seen in your IDA also, but for me, the finding what I see in microscopy is microcytic hypochromic is definitely more favorable than poikilocytosis. These two are not the best answer. I would prefer microcytic hypochromic to the first finding, then anisopoikilocytosis will definitely come together, fine. If it's IDA, obviously the first answer is going to be microcytic hypochromic, fine. Okay, this question also had a little bit of tough time because, yeah, some of them said which of the following is not correct. Some of them said it's multiple choice question. So I'm going with whatever information I got. I'll tell what is the exact finding. You choose whatever is, if it's a multiple choice or if it's all except, you go for that, fine. Clear cell renal cell carcinoma is which of the following statement is wrong regarding clear cell renal cell carcinoma, fine. Pavani, if that's the option, that's not possible. If it's a microcytic, hypochromic will be the right one, fine. It's mostly sporadic. The question is which of the following regarding clear cell renal cell carcinoma is wrong, right? If that's the correct question, most of the clear cell RCC are sporadic, so this is a correct statement, right? So the statement is correct. I'm not saying correct option, this is correct statement, that's all. Occurs due to deletion of long arm of chromosome 3. It's not long arm of chromosome 3, it's 3p. So the statement per se is wrong, not the option, the statement per se is wrong. Clear cell renal cell carcinoma, they do have glycogen lipid, so this is also a correct statement, not the correct answer, correct statement. But they originate from proximal convoluted tubule, so this is a wrong statement. If the question was which of the following is a wrong statement, option B and D will be the wrong statement, right? So if the question was which of the following is a right statement, you're going to go for option A and C. Yeah, 3q or long arm of chromosome 3, both means one and the same, right? Fine. 3p is the correct one. So 3q or long arm of chromosome becomes wrong, fine. So if this is the right question, option will be option B and D, that will be the right answer for this question, okay? They are mostly sporadic and they do contain glycogen and lipid, okay? I'm not going to waste much of time in this question. Everyone should have written this question right. MHC1 binds to CD8 T cell. I'm even not sure if this question came in the exam. If this question came in the exam, it's a jackpot. It's everyone should have written this question correctly, right? Okay. Was there any history in this question, or it was just an image and it was asked what is a tumor? Was there any history? It came, okay, great. It's a simple image, right? You have a blood vessel in the center and you have two layers of the thing. Okay, Midnamik. It's only image, fine. Again, becoming very bad pathologist, the examiners. Still a dual body, but still, even if it's only image given, you should be able to write the right answer. You have a blood vessel center and tumor surrounding them. It's going to be Schiller dual body. It's a classical diagnosis of New sac tumor, right? If I had an age history and a tumor biopsy, I would have preferred it better than asking only an image, but still. Okay. This is the last question in my PDF. I hope this was the image. I'm not sure about it. I think I'm hiding half of it. Let me zoom it out a little bit. Was this the image? Something related to that. A skin was given and 4 things were marked, right? I'm not sure what are the 4 things marked. So I put 1 for A for epidermis. B, whatever I marked is the hair follicle here. C, whatever I marked is sebaceous gland here. And D, whatever I marked is your normal sweat gland, right? Something similar to this. I'm not sure about exact thing. Can you give me the question, Pratmesh? I'll try to discuss that. If it's a merocrine gland, that's fine till here. I didn't get the exact image, so I'm just using a similar image, fine. A gland surrounding the hair follicle should have been a sweat gland. A sweat gland will come into a merocrine gland only. So it should be a small exocrine gland. That's a merocrine gland. That's fine. So option, the one which I marked C here, is a sebaceous gland. This is not the right answer. And B, here in this image at least is a hair follicle. That's not the right answer. A, at least in this image, is an epidermis. That's also not the right answer. Fine. It's definitely doable. This is not a difficult one at least. Fine. Okay. So I had 26 questions here. I'm just going through quickly again from the top just to make sure which all you should have attended easily. This question, can I call it easy? And I need your votes. If you tell easy, if you tell doable, I'll put them into doable. I will say this question it's doable. If you accept, I'll go with that. Okay, TripAdvisors. I will add that also in the PDF. Johab, can you share the question as well? I'll put this into doable one, right? This question is a bit difficult. I do accept it's a bit difficult, so I'll put it into difficult. I'm just counting the doable ones along. Okay, Pratmesh. I'll try to add that as well. Fine. This one I do put into doable, right? This is definitely doable question, right? I'll put the second question into doable. I'll add TripAdvisors to the question, fine. Second question is this doable. Innate immunity is definitely doable. This is easy as well, right? This is also an easy one, right? Third question is easy one. Multiple polyp, I don't know. It's totally based on the image. So since I don't have a perfect image with me, I'll put this for now into difficult category, but I don't know it's based on the image, fine. This match the following, though it looks very big, it's still doable. I'm putting the fourth question to doable. I put 3 for difficulty as of now. Cell and cell appearance, I prefer gastric and pancreas. If so, it's still heavens. Fine. Okay, cell and cell appearance of entosis, it's an old statement. Okay, for now I'll ignore it for now as non-doable one. Pleomorphic adenoma, at least I would prefer it as a doable question. If I want entosis, I'll keep entosis as a doable one. If pleomorphic adenoma, for me, and perineural invasion is definitely an easy finding for a cancer, not for a benign tumor. I'll put it into doable. Sixth question. Fine. This was a PYQ. A PYQ should never be missed, so it's definitely doable. Fine. See, differential expression in genetic material with regards to parents. It's a new statement, so since it's a new statement, I'll keep aside for now. Okay, I'll do a simple. Fine. Chromosome and G banding is a bit doable. I'll add it to the doable one. X-linked dominant Rett syndrome is doable. I'll add it to a doable one. If you have any conflicting opinion, tell me. Not elevated in pregnancy is still a doable. I'll add it to doable one. This is definitely easy. 11th question is easy. Though the history was very complicated for this, the fish image was still an easy one, right? 12. This I would keep into a difficult one for a simple reason that let's say it's more of a disconnect between the history options and an unwanted synovial fluid biopsy, right? I'll keep it on undoable part, maybe on the difficult side. Autophagy, if you have read the question carefully and the options carefully, is a simple one, it's a doable one. Synaptophysin was positive. If that was there, we did read more things about them. That we will put into a doable one still. Okay. Do you want me to put in doable one? This one. Thank you, Joab. I'll just have a look at that. I'm just pasting it. I know Pratmesh. It's fine. I think it's fine, right? Partial aneuploidy is partial deletions. I'll still keep it into the doable part because Credo-Chat is a partial deletion, which I'm sure you know. This fine, low allele frequency is a new concept. It's difficult, we'll ignore. Fine. Not age defining cancers, it's still a doable one, right? It's definitely an easy one. Microcytic hypochromic, you should not miss it. It's definitely easier one. Clear cell carcinoma, which statement is wrong? Though it's a multiple choice question, it's definitely an easy one, right? Okay, MHC1 complex is definitely an easy one. Schiller-Dole body is definitely an easy one. Merocrine gland, you did, though it's not the same image, but that's also doable one, right? So of the 26 question, even if after liberal exclusion, I've got somewhere in 15 questions which are easily doable one. That's more than enough, fine. I'll add that as well. I think I've missed on Human Genome Project. Anemia of chronic disease. What is the question on anemia of chronic disease? Was it regarding ferritin again? Then that's also a doable one, right? Okay. See, the number of questions in pathology is coming close to this time. There was a bit of emphasis of more in genetics. I'll add the 4 questions metnomic. So even after adding the 4 questions, of the 30 questions, if I say if 18 to 19 questions are doable ones, and if you've concentrated on those more, that's where you have to do in the next NEET exam. The difficult ones is going to be difficult for everyone, right? You guys know now that if it's difficult for you, it's difficult for everyone, and the answers might change a lot, because if a technique is coming newly and the questions asked on a new technique, then definitely there can be the change in answer as well. Fine. Okay. So this was, at least with respect to pathology, I would say is a decent paper. It's not a very difficult paper. And medicine, it's a very vague statement for me to make if I should say how many things to get it correct. I would keep, if you get around 75%, you should be in the top 10 to 20 at least. Generally, it was there. 18 in this, of the 30, 18 correct is definitely a very, very good chance. Which protein is carried along with what? Can you explain that, Arpita? I will add, see, DNA fingerprint footprinting, I will leave it to forensic for now. Okay, if you can rephrase the question, Suparna, it shows on the low allele frequency or minimal mutation allele, because there are two differences between minimal mutation allele and low allele frequency. I will get back to that. That's what I said, metnomic. If you can get 75%, you'll be in the top 10 to 20 easily. Because I am not so good in guessing, that's why I put it on the higher end. That's all. Fine. Okay. Okay, I'll take the Delhi Heavens. I'll discuss those as well. I'll add whatever question I have missed and whatever input I've got from you. If I want to change anything, I'll change as well. I'll put it as a PDF hopefully by tomorrow. Fine. So thank you for your time. Hope your INICET went well. It would have definitely went well. Don't worry about the results for now. For now, just go ahead and look forward to your NEET exams. We'll have a couple of special classes more. If you want any particular topic, we'll discuss on that topic. Do ping me on the Telegram group. We'll definitely see what happens. Pratmesh, I wouldn't say it's a luck-based exam totally, but yes, there's definitely a little bit of lady luck required for the exam, for any competitive exam. But I always believe that luck favors the mighty. So you work hard, definitely luck will follow you. Okay, Johab, I'll add them. There are few more questions I have to add. One is regarding plasma proteins, anemia of chronic disease, human genome product, and the IDA matching proteins. Fine. I'll add them and I'll send it to you in the Telegram group. Fine. Chakravarti, I'll do the WhatsApp group. I'll create it. I'll create it soon. I'll do it metnomic. Fine. Okay. As of now, signing off. Bye bye, and have a great night. Thank you. TripAdvisor says there are a few facts in the human genome project you have to verify. Before verifying, I'm not going to say the answer because there are more of theory-based facts. Right? There's no logic behind that. So I have to verify the facts. Definitely, I'll come back with the right answer. I'll put it in the PDF. Fine. Thank you.